This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the April 2026 issue of Child's Nervous System. The paper is titled Endoscopic-Assisted Strip Craniectomy Using a Diamond Drill Bit Attached to a Dural Retractor, a technical paper.
This is a timely topic, Ilara. For our residents and colleagues listening, we've seen a massive shift in how we manage single-suture craniosynostosis. Minimally invasive techniques have largely supplanted open cranial vault remodeling as the preferred approach for these infants. But, as we all know, the Achilles heel of these smaller procedures, especially in infants, is managing blood loss.
Exactly. The authors, Kuwait and colleagues from the University of Wisconsin, point out that while we have tools like electrocautery, ultrasonic bone-cutting devices, and even pharmacological interventions like preoperative erythropoietin or intraoperative tranexamic acid, TXA, each has its limitations. This paper introduces a refined method that uses a high-speed drill with a diamond burr in combination with a novel, attachable dural retractor.
It's an interesting mechanical solution to a biological problem. Let's dive into the why behind the diamond bit. Usually, in neurosurgery, we think of heat as the enemy, right? We irrigate constantly to protect the tissue, but this technique flips that logic.
It does. The diamond drill bit is used specifically because it generates localized heat. That heat effectively cauterizes the bone edges as you're cutting, which potentially reduces the characteristic oozing we see from the marrow space. However, if you're generating enough heat to cauterize bone, you're also generating enough heat to damage the dura.
Which is where this novel dural retractor comes in. Ilara, walk us through the design of the device they described.
It's a relatively simple but clever design. The retractor is a thin, mildly pliable aluminum strip that attaches directly to a standard surgical drill. The authors specified that the attachment screws are recessed. They sit flush with the surface of the device so they don't snag or interfere during the drilling process.
That's a critical detail for smooth passage through a tight craniectomy.
Right. They designed it in two widths, 10 millimeters and 15 millimeters. The distal 1 centimeter of the retractor, which is the part aligned with the drill bit, is the full 10 millimeter width, but the proximal portion, the part under the drill shaft, has a narrower profile. This allows for smooth movement through a 10 millimeter wide craniectomy.
And they mentioned different lengths for different drill configurations, correct?
Yes, they have versions for short straight drills and long curved drills. In the case study they presented, a 3-month-old female with metopic craniosynostosis, they actually switched between those.
Let's talk about that clinical presentation. This patient had classic metopic synostosis symptoms, trigonophaly and hypotelorism, but otherwise normal development. The parents chose an endoscopic-assisted metopic strip craniectomy followed by helmet therapy.
The procedural details really highlight how this tool integrates into the workflow. They used Axiom Stealth neuronavigation to ensure precise midline alignment and to identify the nasion. After a 2 centimeter transverse incision at the hairline, they elevated the gala off the pericranium.
And for the residents listening, note the safety step here. They didn't start with the diamond bit. They created the initial burr hole using a standard 3.0 millimeter carbide match head. Why? To prevent initial dural injury. Once they had that entry point and could safely dissect the dura off the bone, that's when they switched bits.
Exactly. They switched to a 4.0 millimeter round fluted soft touch diamond bit equipped with the dural retractor. They drilled the metopic suture in a piecemeal fashion, maintaining a width of 8 to 10 millimeters from the nasion all the way back to the anterior fontanelle.
I found the drill choice for different segments of the suture very practical. They used the short straight attachment for the proximal portion of the craniectomy, but as they moved distally, they switched to a long angled elite attachment with a 4.0 millimeter coarse diamond bit.
And here is the deep dive point on the technique. They explicitly stated that no irrigation was applied during the drilling process.
That's the key. By withholding irrigation, they promote that bone heating we talked about earlier. The diamond bit cauterizes the bone edge as it goes, and because the dural retractor is sitting right there between the bit and the brain, it limits heat dissipation toward the dura and protects it from both thermal and mechanical injury.
The results in this case were quite impressive. The reported blood loss was less than 5 cc.
Less than 5 cc? That's nearly bloodless for a strip craniectomy.
It is. To put that in perspective, the patient's preoperative hemoglobin was 10.6 and the postoperative hemoglobin was 10.9. They maintained excellent visualization through the endoscope the entire time because the field wasn't obscured by bone ooze.
It's a compelling technical note. However, as with any new device or technique, the authors are careful to state that further evaluation in larger cohort studies is necessary. We need to objectively assess the safety and reproducibility across different surgeons and different types of synostosis.
True.
But the feasibility of using a diamond burr with an attachable protector to reduce bone edge bleeding is a strong proof of concept. It addresses a major perioperative concern in pediatric neurosurgery.
It also highlights the importance of instrument design. By making the retractor pliable and the screws flush, they've tailored the tool to the specific constraints of the endoscopic corridor.
Before we wrap up, Eris, for the residents, why the metopic suture specifically for this case?
Well, the metopic suture is often the first one to close naturally, but when it closes pathologically early, the resulting trigonophaly can be quite severe. The endoscopic approach is ideal here because of the cosmetic advantage of that small 2-centimeter incision at the hairline compared to a traditional bicoronal incision. But because the metopic suture is so close to the midline and the superior sagittal sinus, though it's the anterior portion here, bleeding control is paramount. This diamond bit technique seems to offer an extra layer of security.
And it's worth noting they use TXA as well, following their institutional protocol. It's likely a multimodal approach, TXA for systemic control and the diamond bit for local cauterization.
Exactly. It's never just one thing in the OR. It's the combination of technique, technology, and patient selection. This paper provides a very clear roadmap for how to integrate a novel dural retractor into that workflow.
Well, that's our look at this technical paper from Child's Nervous System, a small 10mm retractor potentially making a big difference in pediatric craniofacial surgery.
Thank you, Dr. Alara, and thank you to our listeners. We'll be back next time with more insights from the cutting edge of neurosurgery.
See you then.